Salmonella enterica serovar typhi is a facultative intracellular pathogen. Unlike many bacteria circulating in the plasma, this serovar survives within the host's immune cells, hiding from the host's immediate antibody response. This behavior creates a significant clinical paradox. While most systemic bacterial infections present with a surge in immune activity, typhoid fever follows a suppressive pattern that contradicts standard sepsis protocols. This chart contrasts a sepsis profile's rising white blood cells against typhoid's hallmark leukopenia and relative lymphocytosis. With early antibiotics, culture yield rapidly drops off. Transient blood bacteria clear, but the deeper infection remains shielded. Treating S. typhi as a standard extracellular threat creates a conflict between traditional diagnostic logic and the pathogen's actual biological behavior. The most frequent clinical error in suspected cases is the premature administration of empiric antibiotics before securing a definitive blood culture. This premature intervention effectively blinds the diagnostic process. It reduces the total concentration of bacteria in the bloodstream below detectable levels, while the primary internal reservoir remains untouched. Historically, this fecal-oral transmission route has made typhoid a primary public health concern. Because the bacteria thrive in contaminated water and unhygienic handling, an accurate diagnosis is essential to track and contain outbreaks. Management must be driven by pathogenesis, mapping the diagnostic timeline to the pathogen's intracellular movement and selecting agents with specific tissue penetration. In enteric fever, the test's timing is just as important as the choice of the antimicrobial. Upon ingestion, the bacteria survive the stomach's gastric acid and travel to the terminal ileum of the small intestine. The pathogen specifically targets M cells within the Peyer's patches. It uses these specialized cells as a gateway to breach the intestinal epithelium and reach the submucosa. This invasion is mediated by its antigenic structure. The somatic O antigen is part of the cell wall's endotoxin, while the flagellar H antigen provides the motility required to navigate to the cell surface. However, the most critical feature for survival is the Vi antigen, a polysaccharide virulence capsule that covers the bacterial surface. When macrophages engulf the bacteria, the Vi antigen prevents phagolysosome fusion. Instead of being digested, the bacteria remain intact and multiply inside the immune cell. The pathogen now inhabits the host's primary immune defense, using the macrophage as a secure vehicle for systemic transport. These infected macrophages enter the lymphatic system and rapidly drain into the bloodstream, creating a phase of primary bacteremia. This map shows the seeding of the reticuloendothelial system. The bacteria are transported directly into the liver, the spleen, and critically, the bone marrow. Invasion of the bone marrow results in endotoxin-mediated suppression of blood cell production. This anatomical colonization is what produces the clinical finding of leukopenia. In the liver, the bacteria infect the Kupffer cells, which are specialized liver macrophages. This causes mild inflammation and a corresponding rise in AST and ALT levels. In typhoid, these enzymes typically stay within 3 times the normal limit, a stark contrast to the massive elevations seen in viral hepatitis. The unique signature of leukopenia and mild transaminitis is a direct consequence of the pathogen's specific anatomical preferences.
Timing is the most important factor in diagnostic sensitivity. In the first week, during primary bacteremia, the blood culture is the gold standard for isolation. But the moment antibiotics are introduced, the sensitivity of the blood culture drops. The sample no longer reflects the true bacterial load hidden in the tissues. The bone marrow culture, however, remains highly sensitive throughout the course of the illness. It is the most reliable test, even after the patient has started medication. Because the bacteria are sequestered inside macrophages within the marrow, they are shielded from the systemic concentrations of many antibiotics. Serological tests, like the Widal test, only become useful later as antibodies to the O and H antigens develop. However, these are often unreliable due to previous vaccinations or cross-reactivity with infections like malaria. A diagnosis must be based on the pathogen's location at that specific moment in the timeline. Effective pharmacotherapy must target 2 compartments: the extracellular bacteria in the blood and the intracellular reservoir in the immune cells. Ceftriaxone, a third-generation cephalosporin, inhibits cell wall synthesis. It is highly bactericidal and remains a primary choice for severe systemic bacteremia or complicated cases. But we must account for extended-spectrum beta-lactamases. These enzymes drive XDR typhoid strains that are increasingly resistant to cephalosporins. Azithromycin offers a different advantage. It achieves very high intracellular concentrations, allowing it to reach and eliminate the bacteria sequestered within the macrophages. Fluoroquinolones like ciprofloxacin were once the standard, but resistance is now widespread. Mutations in the GIRA and PAR-C genes have made these drugs less effective in many regions. These should only be used as targeted therapy once laboratory testing confirms the strain is susceptible. Successful treatment requires selecting an antimicrobial agent whose unique pharmacokinetic profile perfectly matches the pathogen's hidden intracellular sanctuary. Without intervention, the disease progresses to week 3, where necrosis of the Peyer's patches leads to intestinal perforation, a dangerous stage with high mortality. The pathogenesis-driven protocol begins with identification. We look for continuous fever and the characteristic suppressive lab markers of leukopenia and mild transaminitis. The critical step is immediate diagnostic sampling. A blood culture or PCR must be drawn before the first dose of antibiotics is administered. If the patient is already on medication, the protocol shifts to the bone marrow. This allows the clinician to bypass the interference of systemic antibiotics and secure an accurate culture. Adhering to this sequence ensures the clinician has the data necessary to adjust therapy based on actual susceptibility. Early detection relies on identifying the suppressive markers in the CBC and LFTs that signal an intracellular invasion rather than a typical bacterial surge. The goal is to ensure the antibiotic reaches the bacteria where they hide. When the drug penetrates the cell, the intracellular reservoir is eradicated. Stewardship requires selecting drugs like azithromycin or ceftriaxone based on the patient's severity and the local resistance profile. Every clinical decision must be informed by the specific biology of the pathogen. Managing typhoid fever is a matter of outmaneuvering an intracellular pathogen through precision timing and compartment-aware therapy.